طيب. So today we'll start session on medical treatment of heart failure. So let's start. So heart failure is a clinical syndrome characterized by typical symptoms, which is breathlessness, ankle swelling, and fatigue that may be accompanied by signs, which is elevated GVP, pulmonary crackles, and peripheral edema. And this is usually caused by either structural problem or functional abnormality. And this will result in reduced cardiac output or elevated intracardiac pressure at rest or during stress. So three things on this definition in order to have the heart failure definition: typical symptoms, structure or functional abnormality, and the result, which is the damage, which is either reduced cardiac output or increase intracardiac pressure. And again, this could happen at rest or during stress. So you always seek a test that is done at stress if your pretest probability is high to have heart failure, but your tests are negative on rest. If we see the body response to a failing heart, so what we know from physiology that cardiac output is a result of heart rate multiplied by stroke volume. And whenever decreased cardiac output happen, either due to an insult, due to ischemia, due to cardiomyopathy, myocarditis, etc., two things happens at the same time: decreased expression of baroreceptors and decrease in the renal perfusion. This will decrease to sinus, increase expression of sinus node, and through acetylcholine, this will increase the heart rate. So heart rate is one of the end results of cardiac output decrease. And decreasing renal perfusion will activate the RAS system, which also results in angiotensin II activation. This will lead to increase in the preload, afterload, and in the preload through aldosterone system. So RAS system and sympathetic nervous system. And the end result will be tachycardia through the same mechanisms that we mentioned, vasoconstriction again through the same mechanism, salt and water retention, which is results of increased preload and afterload. And whenever the volume distribution will happen, acute decompensation will happen. So clinically, we tend to divide the heart failure to left and right. So left-sided heart failure is congested lung and S3 gallop. And at the end, there will be hypoperfusion. With the time, this hypoperfusion will result in right-sided heart failure in 90% of the patients. So right-sided heart failure is caused mainly by left-sided heart failure, except for rare cases. And this will manifest as increased GVP, ascites, lower lymphedema, and gut edema. On the presentation, we should look at the age of the patient and gender, as these might affect the characteristic and profile of the patient, whether it's acute or onset or chronic, and the common complaint, which is shortness of breath, orthopnea, PND, and swelling. These are the results of volume retention, and nausea and confusion result of hypoperfusion. Past medical history, you should look at the risk factors for coronary artery disease, family history of any cardiomyopathy, drug history like ethanol, pregnancy, history of recent viral infection, and as this might lead to cardiomyopathy. On clinical examination, you should focus on rails and S3, and these two are the constitute the left-sided heart failure, and edema and JVB and ascites. These express the right-sided heart failure and perfusion of status of the body. If we look at the classification of heart failure, so based on the symptoms, we have the well-known NIHA classification from 1 to 4, stages from A to D, severity, warm, cold, wet, and dry, and combination of these, which we'll talk about. We have the type of the heart failure, which is either heart failure with reduced ejection fraction or preserved ejection fraction, and etiologies like ischemic, dilated, hypertrophic, obstructive, or peripartum, and etc. So we'll talk about each one of these in details. So if we talk about symptoms of heart failure, we have the well-known NIHA classification, and this classification will serve as good time in first putting the symptoms of the patient on the grades will let you know how severe is the disease, will let you know the prognosis of this patient, and will let you know what medication should you use for such patient. So if we talk about Class 1, there is no limitation of physical activity, and more than ordinary activity will cause symptoms. Class 2 is slight limitation of physical activity, comfortable at rest. Ordinary physical activity will cause symptoms. Class 3, there is marked limitation. Less than ordinary activity will cause symptoms. And Class 4 is shortness of breath at rest. And if we talk about stages of heart failure, because this is kind of new in the last few years and it's developing, and it's important, comes from prevention. So if you know the first 2 stages of heart failure, you would prevent the patient from going to stages C and D. So stage A is at risk, where you have a normal ejection fraction, you have no symptoms, and treatment is lifestyle. For example, you have a risk for coronary artery disease, you have a risk for example, family history, so you do the lifestyle modification to prevent going to the second stage, where you are asymptomatic, but you have an ejection fraction between 25 and 50. So this is a structural abnormality, but no symptoms. And the treatment usually is beta blocker and ACE inhibitor. Stage C, where you will see most of your patients who get admitted or follow up in the clinic, where you have symptoms and an ejection fraction between 25 and 50. And usually there is symptoms, and the patient should be on optimal medical therapy. And lastly, stage D, where you have end-stage heart failure, your ejection fraction is less than 25, and symptoms are usually refractory. And those patients will require advanced heart failure treatment. So if we look at this, if you see stage A, where high risk with no symptoms, so mostly it's risk factor reduction and patient and family education. Stage B, you have a structural heart disease but no symptoms. So you give those patients ACE and ARBs and beta blocker in selected patients, and you treat all risk factors for heart failure. Stage C, all of these are considered: ACE, beta blockers, and then dietary sodium restriction, diuretics and digoxin. Then you go up with them, you give them cardiac resynchronization if there is left bundle branch block, revascularization, mitral valve surgery or clip, and then you can consider multidisciplinary team for those patients. The last stage, which is refractory symptoms requiring special intervention, where you need inotropes, VAD or a transplant, and at the end you might need hospice if there is no solution. And if we talk about severity, according to the perfusion status and volume status of the patient. So there are four stages. We have warm and dry, and this is the usual place of the place where you want your patient in. You want the patient warm, so well perfused, and dry without volume overload. And then you have warm and wet, and this is the place where you see most of your patients. They are well perfused, but they are congested. And then cold and dry. Those patients are hypoperfused, but does not have a lot of volume in their body. And the worst stage, which is cold and wet, and options are usually limited on those patients since they are hypoperfused. At the same time, that we need to get fluid out of their bodies. And if we talk about types of heart failure according to the systolic function, so heart failure with reduced ejection fraction less than 40, and signs and symptoms. Heart failure with mildly reduced ejection fraction is 40 to 49 with signs and symptoms, and additional supportive criteria, which is BMB, LVH, and left atrial enlargement with diastolic dysfunction. Heart failure with the preserved ejection fraction, where you have ejection fraction more than 50, signs and symptoms, and increase in BMP, LVH, and left atrial enlargement. And for the exact definition, you will be having a lecture later on about heart failure with preserved ejection fraction, where you will have the details of this. So if we look generally to the etiologies of heart failure, we see coronary artery disease, one of the most important things, since it's reversible. It has to be detected. Myocardial infarction or chronic stable ischemic heart disease. Myopathies in general, which is dilated, hypertrophic obstructive, restrictive cardiomyopathy, peripartum cardiomyopathy, or myocarditis. And all valves might lead with varying degrees of severities, might lead to heart failure. And the treatment for this is, of course, valve intervention if it is done at a good timing. Conduction abnormalities or arrhythmia-induced cardiomyopathy, tachycardia and rapid AF, complete heart block, and pericardiac cause, like constrictive pericarditis. The workup of patients in general include ECG, where you will get a lot of information about it. If there is cues in your ECGs which indicate infarcts, LVH, left atrial diameter, arrhythmias or AFib, how wide is your QRS, and if there is left bundle branch block or electrical alternance, which might alert toward severe heart failure. Your chest X-ray might show effusion, edema, increase in vascular marking, and curly B lines. Echo is a cornerstone in your investigation. You should evaluate your EF there and see the diastolic function, sizes of the chambers, and any structural abnormality. Coronary artery disease, you should rule it out by doing coronary angiography in selected patients, CT for intermediate possibility, and nuclear scan for those patients who might have some risk factors. Cardiac MRI is important in detecting viability of the tissue, detecting infiltrative disease that is difficult to diagnose by echo and by and clinically. Congenital abnormalities are usually illustrated in cardiac MRI more than echo. And estimation of RV function and estimation of RV morphology is better generally with cardiac MRI. So laboratory testing, you will do your CBC, looking for infection or anemia, as these might lead to decompensation in heart failure. You would look at your renal profile, looking at the BUN and creatinine and detecting any proteinuria. You will look at the liver enzymes like AST and ALT and bilirubin. Those might be high if you have hypoperfusion. ProBNP is an important tool in basically rolling out because it has high sensitivity. So if it is less than 100, it makes it unlikely. Special consideration, consideration of diagnosis if you have a young patient who have number more than 450, mid-age of more than 900, elderly 1800. These numbers are arbitrary, so you take them with caution, but generally it's helpful for ruling out the disease. Others like iron and TSH. So generally treating patients is either ambulatory, decompensated, or in cardiogenic shock. So if we remember our pathophysiology that we talked about in heart failure, angiotensin 2. So we use generally ACE inhibitor, ARB, or ARNI. For sympathetic nervous systems, we use beta blocker to suppress this. And we used aldosterone for mineralocorticoids like spironolactone and epinephrine. And for volume overload, we used diuretics. So what are the novel drugs, therapies for heart failure? We have the ARNI, we have ivabradine, and SGLT. And they are not really novel right nowadays because it has been years since discovery, but generally these are the most recent medications. And for end-stage heart failure, special workup, special procedures like mitral valve clipping, LVAD, total artificial heart transplantation, or palliative care. And this, you will have a special session about heart transplant and advanced heart failure treatment at a later lecture. If we look at anti-RAS, generally ACE or ARBs, class of recommendation is 1. There are multiple studies, solved consensus, and many other studies that prove that these medications will work in patients with heart failure. We generally start with low dose and observe renal function tests in 1 to 2 weeks with every change. It may be given in a stable chronic kidney disease, and you should avoid those if the potassium is more than 5. Rising creatinine less than 30% is okay, so you should not change your management. This is expected and indicates that the medication is working. 30 to 50%, you just reduce the dose by half. And if it is more than 50%, you should DC and look for bilateral renal artery stenosis as possible diagnosis. The uptitration should be up every 2 to 4 weeks to a maximum dose guided by creatinine and blood pressure. And these are the types of some medications, types of ACE inhibitor and ARB, and their starting dose and targeting dose. If you look at ARNI, which is sacubitril and valsartan, class of recommendation is 1. So we usually start the low dose, 50 PID for new patient. If your patient is already on ACE ARBs and you want to change it, then you start with 100 PID. If he's on ACE or ARB, you should allow 36 hours watch. and you should never combine those two medications. Caution, the same caution as ACE and ARBs. And you should up titrate every 2 to 4 weeks to a maximum dose of 200 milligram PID, and this is guided by creatinine and blood pressure. Neprilysin inhibition, this is important. As we all know how ARB work by inhibiting angiotensin 2. But the new thing that is present in interest is sacubitril, which is a neprilysin inhibitor. So generally, neprilysin is a medication, an enzyme that leads to degradation of natriuretic peptide. And these natriuretic peptide are important in increasing natriuresis and diuresis, and they decrease the cardiac fibrosis and hypertrophy. So once degraded, this effect will go away. So sacubitril prevents this breakdown of these peptides. So that is how sacubitril works. So who to switch to ARNI? Generally, any patient who had heart failure with reduced ejection fraction, EF less than 40%, NIHA class 2 to 3, full anti-heart failure medication, clinically stable, and good systolic pressure. Should not switch if you have previous angioedema or pregnant lady, concomitant ACE, low GFR, or high potassium more than 5.6. So for beta blockers, evidence is obvious, and generally the medication that is approved for this is bisoprolol, metoprolol, long-acting, and carvedilol, and also nebivolol, which is not mentioned here, but it's also approved. The up titration is every 2 to 4 weeks, and you should aim for systolic blood pressure more than 90, heart rate less than 70. And generally, asthma and COPD are not contraindication for beta blocker. Rather, an active airway disease is the contraindication. So ivabradine, a lot of talk about it. So generally, it can be beneficial in reducing heart failure hospitalization. It's general indicated for class 2 to 3. It's for stable chronic heart failure with reduced ejection fraction. And generally, it's indicated for those patients who already receive a goal-directed medical therapy, including a beta blocker at maximum dose. So, in sinus rhythm, the patient will be eligible if he does have heart rate of 70 or greater at rest. Note that it's not a substitute for beta blockers. So if your blood pressure does not allow it, and you don't want to use your beta blocker, because this is not a substitute. It's not for hemodynamically unstable patients like cardiogenic shock. So ivabradine generally improves hemodynamics. It reduces the cardiac remodeling and reduces hospitalization. Definitely, it improves symptoms and quality of life. In the increased survival, evidence is controversial. So we have two studies. The first study, beautiful, did not show improvement in overall primary outcome. Then SHIFT trial done, it showed improved in overall primary endpoint, which is heart failure, cardiovascular death, etc. But keep in mind, there are caveat to this study. Later on, many studies done, the meta-analysis of those studies showed that there is no difference. And if we analyze SHIFT trial, the benefit was mostly for those patients who have a heart rate more than 87. So generally, exceeding a heart rate of 70 does not really makes a difference to get it lower to like 60s and 50s. So the higher the heart rate, the more indication for you to give your evaporative. It's generally safe and cost effective. Mineralocorticoid antagonists. So we have spironolactone and epinephrine in this family, and it's indicated for those patients who have ejection fraction less than 40. So generally, it blocks the aldosterone activity and reduces sodium and water retention. It has antifibrosis action on the heart. You should avoid in acute kidney injury, CKD stage 3, generally creatinine more than 200 or potassium more than 5.6. Antidiabetic therapy. So there is bidirectional relation between diabetes and heart failure, and there is an entity called diabetic cardiomyopathy, although we don't recognize it very much, but it exists in the literature and it was described by many articles. So what are the options that we know? We have the metformin, insulin, sulfonylurea, TZDs, DDP4 inhibitors, GLP-1 inhibitors, and SGLT2 inhibitors. So best options, metformin is safe in heart failure. You should use it with caution if you have severe renal or hepatic dysfunction, but generally it is safe. If you are starting insulin new patient, then you should expect some sodium and water retention. So you might want to increase your diuresis if those patients will be shifted to insulin. Sulfonylurea in heart failure generally causes frequent hypoglycemia and might worsen heart failure, but this is in cohort, but not in RCTs. TZDs contraindicated in heart failure. DDP4, it increases heart failure hospitalization with very small benefit. GLP-1, no benefit in heart failure. And SGLT2 inhibitors have another story. So how does it work? Basically, it promotes the urinary excretion of sodium and currently indicated in treatment of type 2 diabetes. But then at multiple trials done, which we will cover now. So many trials, empiric cannabis R, Credence, Declare Timmy 58, Vertis. So generally, 2016 guidelines, the European guidelines, empagliflozin is indicated for treatment of heart failure. It does reduce the cardiovascular mortality and heart failure. And again, when we talk about dapagliflozin, which is also another SGLT2 inhibitor, it showed in the studies that among patients with heart failure and reduced ejection fraction, risk of worsening of heart failure or death from cardiovascular causes was lower among patients who received dapagliflozin. So major trials of SGLT2 inhibitors are so many. I mentioned some of these. Many trials were not mentioned, but generally, all of these showed significant reduction in cardiovascular events. And they just started in 2015, the first trial in the outcome. So overall, to just summarize these trials, SGLT2 inhibitors improve outcomes in heart failure with a reduced or preserved ejection fraction. So Emperor reduced, Emperor preserved, all showed good outcome. It also reduces the progression of kidney disease. The GFR should be 25 and 75. That's what's tried in the trials. And these findings are irrespective of presence of diabetes or not. And the outcomes are driven mainly by reducing rehospitalization of heart failure. So we'll skip this. We'll talk about side effects. Sometimes you might have side effects that might need to start to hold the medication or stop it. So in the trials, it showed that it increases UTIs. It might increase the incidence of diabetic ketoacidosis. And in those who have who are dehydrated, since it promotes glucosuria, it might cause acute kidney injury. And most of these are reversible. So let us have a recap on drug therapy in heart failure. So we talked about anti-RAS, which is ACE inhibitor, ARB, ARNI, beta blockers, which is carvedilol, metoprolol, bisoprolol, MRAs, which is spiro and ibrelone. And in fact, the fourth one is SGL2 inhibitor, should have a column near MRA. But this is I forgot just to change it here. And add-on therapy, diuretics and digoxin, and nitrates and hydralazine. Briefly about non-pharmacological treatment. So generally, salt restriction to 2 grams per day is very helpful in patients with heart failure. Fluid restriction to 1.5 to 2 liters per day. Activity of 20 minutes at least for 3 days per week. Weight should be stable, dry weight, and if you gain more than 5 kilograms per week, then you should do an intervention. Either you increase your diuretics or restrict the fluid more, or visit your heart failure physician or nurse. And complaints, which is time, dosing, and frequency, and avoid non-steroidal anti-inflammatory drugs. Device therapy, and briefly, it will be covered by somebody else at later lecture, but generally CRT and ICD, these are indicated for NEHA class 3 to 4 with maximum medical therapy for 6 months, and EF of 35 and left bundle branch block. And ICD for any patient 30%, less than 30%, 40 days post-MI, or EF of 35 with NEHA class 2 to 3. And a secondary prevention, of course, for patients with VT-VF with hemodynamic instability. Heart failure management in summary. So stuff that doesn't work. So oral anticoagulation, we used to give warfarin for those patients who have low ejection fraction. This is not anymore. Vitamins, they do not have any benefit in heart failure. CPAP, so we use it only for obstructive sleep apnea. It causes harm if you have central apnea that is caused by heart failure. So generally, it's only indicated for obstructive sleep apnea. Diabetes, strict HbA1c is not advised, as we know from a core trial. Those who have A1C controlled, very controlled, less than 7%, did have mortality more than those patients who have higher A1Cs. And generally, statins does not have any role in heart failure therapy. So advanced heart failure therapy, again, we'll talk about it in other lecture, but generally mitral clip, LVAD, total artificial heart, and a transplant. The take-home message here is to diagnose heart failure, classify heart failure, aim for optimal medical therapy, and need for careful follow-up, identify when things goes bad, and options beyond medical therapy. We want to refer for a specialist for advanced heart failure for further management. Generally, if your systolic blood pressure is dropping, if you have a cardiac dysfunction with severe LV dysfunction, less than 25, if time of medical therapy is more than 6 months and need admission more than 2 times per year, optimal medical therapy is failing and patient is having symptoms. Generally, contraindication for LVAD is they have more than 3 and above, optimal medical therapy not achieved, ejection fraction more than 25, vascular disease, age more than 65, dialysis or disability. These are examples of medications that we use in heart failure. You should be familiar with those, as your patients might present color or something like this, or generic name. What's optimal medical therapy? So maximum dose of anti-RAS valsartan 160 BID, lisinopril 40 OD. Maximum dose of ARN is 200 BID. Maximum dose of beta blocker is 25 BID or metoprolol 100 BID. Maximum mineralocorticoid antagonist is spironolactone 50 milligram daily, evaporating 5 or 7.5, CRT if indicated, and minimum or no diuretics. So your diuretics should be tailored to the clinical status. Generally, the patient should be euvolemic, they have class 1, systolic blood pressure of more than 90, and heart rate of less than 70. Thanks very much for your attention. We'll take the questions now, and then we might proceed for some MCQs.
يعطيك العافية دكتور. I have a question regarding the new medication اللي هو Versiquat. What is our stand from Versiquat so far?
So that is a very good question. Still, the evidence is not very strong. Still, the recommendation will come up for this medication. So this is a new medication. Still, I don't have until now an impression about it. Newer conferences and recommendations will come up for this. Until now, to be honest with you, I did not analyze and look at the study in detail myself. I just looked to the results of the study. So still we need some time before deciding upon considering this medication in heart failure treatment. الله يعافيك يا هلا.
Doctor, can I ask a question, please?
Sure.
What about digoxin? We know that digoxin, according to the DIG trial, it reduces hospitalization. So what is the place in the new recommendation about digoxin?
So it is recommended for those patients who have uncontrolled heart rate, and if they have symptoms despite optimal medical therapy. So generally, since that doesn't reduce the hospitalization, it doesn't reduce the mortality, usually it's skipped until last. The problem of digoxin that generally digoxin works better if your patient is not physically active. Your digoxin you have to monitor for toxicity. Of course, you know that many of our patients with heart failure have CKD. So generally with CKD, we tend to use digoxin less. So these are some few restrictions of digoxin, but generally it is helpful, especially if your patient does have atrial fibrillation. So you will have two at the same time. You control your heart rate with digoxin, and you improve the symptoms and rehospitalization.
Okay, doctor. Thank you.
You're welcome. Any other question?
We're good, Doctor.
Okay, so we have how many minutes left? Probably.
يعني عندي لين 11 ونص تقريبا.
Okay, so we'll take few MCQs. So of course you will have a separate session for MCQs at the end of heart failure review, but I'm just doing this as we have time to review. So a 56 years old woman who's active and completely asymptomatic present to your office for routine evaluation and has the following findings: ECG, regular sinus rhythm, heart rate of 78 and no conduction abnormalities. Chest radiograph showed mildly enlarged LV with no pulmonary congestion. Echocardiogram EF of 30%, moderate LV dilatation. The patient is otherwise normal, but a family history of mother who had sudden cardiac death at the age of 45 and a sister that was recently told of an enlarged heart. She had 3 children of childbearing age. Exercise testing revealed no evidence of coronary ischemia, and her maximal O2 consumption was 75% predicted. Further recommendation should include A. Digoxin, diuretics, ACE inhibitor, beta blocker, genetic counseling, and ICD. B. ACE inhibitor, beta blocker, genetic counseling, and ICD. C. Genetic counseling, close follow-up, and initiation of therapy when symptoms of heart failure develop. D. Transplant evaluation. And E. Biventricular pacemaker. So we'll go back to the question so you can read it. So a 56-year-old woman, her heart rate is 78, no conduction abnormality, no pulmonary congestion, EF is 30%, no coronary ischemia, so which one of these?
B.
So the answer is
B.
B. Okay, so B is the right answer. So if we analyze each one of these, digoxin and diuretics, she's not volume overloaded, and digoxin, the heart rate is 78 only. So these medications are not indicated. So B is the right answer. ACE, beta blocker, genetic counseling, and ICD. C, you cannot leave this patient without therapy, of course. D, transplant evaluation. The patient does not have a lot of congestion, does not have a lot of admissions or any evaluation for transplant. And biventricular pacemaker, of course, the patient does not have bundle branch block or abnormality in the conduction. So whenever you're solving a heart failure scenario, concentrate on few things. First, symptoms and history, more than etiology of heart failure. Should concentrate on the vital signs. Pulse will tell you if more than 80, then you need to consider beta blocker or digoxin. Blood pressure, if high, then consider antihypertension medication, vasodilators. Volume status, if overloaded, then you should consider diuretics. Echo, if low EF, you should add aldosterone antagonists. ECG, looking for new AF for cardioversion. And if there is left bundle branch block and low EF, then ICD or bive ICD. So let's do this question. 62 years old woman who has ischemic cardiomyopathy and ejection fraction 30%. Is unable to walk 100 feet on level ground due to dyspnea and exertion. She described two-pillar orthopnea and extremity swelling that is stable but denies paroxysmal nocturnal dyspnea, palpitation, or syncope. Several years ago, a dual-chamber pacemaker was placed due to symptomatic high-grade AV block. These are her medications. ACE, ARB, MRA, furosemide, aspirin, and simvastatin. So generally, ischemic cardiomyopathy, low ejection fraction, symptomatic now, orthopnea, lower extremity swelling that is stable, no BND, palpitation, or syncope. Chest X-ray, cardiomegaly. ECG, QR restoration of 155. The next appropriate step should include increase furosemide dose, initiate ARB, initiate nisretide, or upgrade to CRT.
You can upgrade to CRT.
Excellent. So the question tells you that the patient is somewhat overloaded, but not terribly overloaded. So ANC is not the answer to the question, and ARB is in a good dose with a good blood pressure. So this is not the answer. So the patient does have a wide QRS complex. At the same time, she's still symptomatic. So this is an indication to have upgrade to CRT. A 53 years old man with multiple atherosclerotic risk factors, including hypertension, hyperlipidemia, tobacco use, presents with 6 months history of dyspnea on exertion and exertional chest tightness. He has orthopnea, PND. Echocardiography reveals severely dilated LV with an EF of 20% and global ventricular hypokinesis. ECG is normal. What's the next step in diagnostic evaluation? Holter, stress test with measurement of maximal O2 consumption, coronary angiography, or heart transplant evaluation. So the question generally tells you that there is a lot of risk factors for coronary artery disease and presenting with shortness of breath, chest tightness, orthopnea, PND, and echo, severely dilated LV with low EF.
So in this patient, you need to rule out coronary artery disease.
So you will go with
coronary artery working. Yes.
Excellent. So Holter monitor does not serve you a lot of service here. ECG is normal. Stress test with measurement of maximal oxygen consumption. You can do this only in very long stem history where you have multiple admissions, a low EF, a patient who had done everything before doing maximal O2 consumption. This is pre-transplant work. Coronary angiography is the right answer, and even heart transplant evaluation, still we are not there yet. So the answer is coronary angiography. Next question, 76 years old man who was admitted to the hospital with pulmonary edema. He has a long history of coronary artery disease, has had 2 prior MIs, but has been evaluated by physician for the last 2 years. Medications include aspirin, 81 daily, metoprolol, 25 twice daily, furosemide, 40 mg once daily, and izardil, 30 mg TID. While in hospital, he was treated with furosemide intravenously and had 9 kg weight loss in 2 days. That's a lot. He was then switched to furosemide 80 mg PID in the 3rd day of the hospital. Echocardiogram showed EF of 15%, dyskinetic apex. On 4th day, he was started in Joxin 0.125 and lisinopril 10 mg daily. The same day, his blood pressure decreased from 100/50 to 70/40, became lightheaded. You are asked to recommend additional medical therapy. These are the vital signs. I know the slides are not clear, but let me just try to Arjit. Blood pressure of 90/50 supine and 80/40 standing, heart rate 100 regular, physical exam, lungs are clear, GVP is flat, extremities no edema, mucous membranes are dry, laboratory potassium 3.7, creatinine 1.3 on admission increased to 2.3. 2 days later, chest X-ray is clear. Adenosine systemic scan showed fixed anterior septal and apical perfusion defect, but no scheme. Which one of the following constitutes the most appropriate management? Start inotropic therapy, hold diuretics Izardine, but continue rest of his cardiac medication with careful monitoring, switch lisinopril to losartan, or hold metoprolol. So let's read the question again. So he's in furosemide 80, he had 9 kg weight loss in 2 days, then he had a drop in blood pressure. Creatinine has increased. So which one of these?
I think B.
B.
Okay. So excellent. So overdiuresis before initiating treatment with ACE inhibitor can result of excessive activation of RAS system and hypotension. This is common. We see this especially in the first admission with heart failure. Many patients will go into hypotension and acute kidney injury because we sometimes overdiurese the patient in the first session. So because of the recommendations to just start the medical therapy whenever the patient is dry, some physicians might overdiurese those patients. And when the patient is totally dry, starting ACE will give you this hypotension and acute kidney injury. So the question here is testing whether this is cardiogenic shock or not. Which of the following medications is not associated with survival benefit in systolic heart failure patients?
B.
B. Excellent. So all of you know this. Good. Which of the following answers is incorrect regarding central sleep apnea and chronic heart failure? This kind of difficult questions, but you might have one of these in the boards. It's characterized by repetitive episodes of apnea hyperventilation, occurs predominantly during non-REM sleep, occurs in 33% to 70% of stable heart failure symptoms, is not associated with severity or prognosis of heart failure. Optimization of heart failure therapy is the mainstay for treatment. So the question is asking about which is incorrect. So what is correct? What are the statements that you guys are sure is correct?
A is correct.
Repeated, so apnea hyperventilation. Anything else? So answer is D. It is associated with severity and prognosis of heart failure. And this is the message. All of these are just distractions, the statements. So the thing is, central sleep apnea is just like hyponatremia, just like presence of atrial fibrillation, just like presence of many factors, is one of the indications of severity of heart failure. Good. A 67 years old man with severe diffuse three-vessel disease coronary presents for outpatient follow-up after recent heart failure hospitalization. He has been hospitalized for cardiac reasons 6 times in the past year. A typical episode starts with chest tightness, quickly progresses to pulmonary edema. The patient has numerous surgical consultation and has been over surgery because of non-graftable distal vessels. So he was denied coverage. He has a history of COPD, currently not requiring medical or oxygen therapy. Viability testing showed large area of ischemia with fixed defect. His ejection fraction is 35. These are not clear. I'm sorry for this, but these are the usual heart failure stems. They are very long and you just need to read and read. So medication, lisinopril 40, furosemide 80, digoxin 0.25, aspirin 325, izardine 60, TID, Plavix 75, atorvastatin 40, nifedipine 30. Vitals are stable, heart rate is a bit higher, lungs are clear on auscultation, GVP with S3 present, extremities with no edema, creatinine 1.3, potassium 4.7. ECG and X-ray were unremarkable. The most appropriate next step in the management includes at low dose, cardioselective beta blocker antagonist and titrate as tolerated, stop nifedipine and add hydralazine, stop nifedipine and add amlodipine or referred for EECP.
So the answer is I need to add beta blocker.
Okay. Okay, so that is correct. So the message here is that if the patient has COPD, this is not contraindication for beta blockers. Okay, especially that is mild or labeled as COPD, because many physicians will just avoid beta blockers just because of this label. Heart failure prognosis most strongly with which of the following? So all of these have been associated, but one of them is
I think the E is the correct answer.
E diastolic dysfunction. Okay. So answer is A. So the two if you ask this question 15 years back, you would have an answer of NEHA class. Okay. So NEHA class is the most prognostic parameters in 15, 20 years back. But then we came to know that resting EF is one of the most important indicators. Still in the books that is written between 2012, 2015, you will have resting EF. If it is severely reduced, the more severe is the heart failure and the prognosis. Then we came to know that the creatinine is the most powerful indicator for mortality. Increasing GFR is most important than decreasing EF. Decreasing GFR. 46 years old woman with a history of breast cancer in remission, presents with 2 weeks history of dyspnea, on-exertion, and weight gain. She does not have any history of cardiac disease, but has a history of hypertension and type 2 diabetes. She presents to the emergency room because she now has shortness of breath at rest. She denies other cardiac complaints. On admission, her creatinine is 1.2, potassium 4.4. A1C is 6.4, blood glucose is 123, LDL 112, HDL 32, triglyceride 188, BMP is high at 2,200. ECG sinus tachy 110, interventricular conduction delay with a prolonged QRS interval of 128. IV diuretic therapy in the emergency room, she gets admitted. Echo dilated LV of 7 centimeter. EF 10 with spontaneous contract. On day 3, she undergoes coronary angiography, reveals angiographically normal coronary artery. ACE inhibitor and beta blocker are started during the hospital course, and she tolerates these with modest improvement in her symptoms. Which of the following is the best additional treatment choice in her patient? CRT without defibrillator or with defibrillator, or aspirin or aldosterone antagonist or statin. So this is the stem of the question to read it. Okay. Do you still want to see the stem of the question? D, aldosterone antagonist. Excellent. So basically, aspirin and statin are out because this is not coronary heart disease. C and E. CRT with defibrillator or without defibrillator, you cannot do this unless you are on optimal medical therapy. So optimal medical therapy first, then device therapy. Even if he tells you that, because this question made it clear 128, but sometimes they fooled you with the wide QRS complex, but still the patient is not on optimal medical therapy. So the patient should be in optimal medical therapy for at least 6 months before trying any additional thing. 42 years old man with idiopathic dilated cardiomyopathy for 7 years is in transplant list in other state. ICD was placed 4 years ago. While on vacation, he acutely had decompensated heart failure, dyspnea at rest, nightly paroxysmal nocturnal dyspnea, orthopnea, edema, lightheadedness. EF has been documented to be 12%. Medications: lisinopril 20, digoxin 0.25, warfarin 2, furosemide 120 daily. Vitals: 82/64, heart rate of 120, respiratory rate 36, moderately labored, oxygen 86 on room air, increased to 94 on 4 liters nasal cannula. Physical examination: he looks in moderate respiratory distress, difficulty completing sentences, crackles halfway up the posterior chest wall on auscultation, GVP located at the angle of jaw, large P waves, extremities cool, grade 3 edema. The most important medical therapy at this point include which of the following? Excellent, D. So the question basically wants you to know that this is cardiogenic shock. Extremities cool, grade 3 edema, high GVP, crackles, blood pressure borderline, low EF, 86% of room air. These are indicators that the patient is in cardiogenic shock. He cannot tolerate any of these medication. One question lastly, about the heart transplant, this will be covered later, as I said, but a 25 years old man on cardiac transplant 4 years ago due to severe myocarditis has done well post-transplant but noticed progressive dyspnea on exertion over the past 6 months. Echocardiogram EF 50% with apical and inferior hypokinesis. The most likely cause of clinical deterioration include which of the following? Excellent. So always coronary artery vasculopathy is a complication that you will have if you have a perfect patient with no rejections and others. Okay, thank you very much. We conclude our session for today. Any questions before we leave?
الله يعطيك العافية دكتور جزاك الله خير. دكتور كان في first questions في الام سي كيوز.
Yes.
هذاك البيشنت يعني he was asymptomatic. ايش الرول اوف الارني والدابا at this point؟
Okay.
كان just low ejection fraction اللي هي عندها genetic family او عندها family history.
Okay, let me see the question.
السؤال اللي قبل هذا. Yes, this question.
Yes. Okay. So.
يعني هي ما كانت الخيارات بس أنا بتكلم in real life يعني what is the role of ARNI, DAPA?
Yeah. So all of these are indicated definitely. So the patient should be on ARNI or so. Previously, this question when I put it, the ARNI was the paradigm trial that you know, and the recommendation was for those patients who have been established on ACE and ARB. Okay. So there was no room, for example, if you admitted a patient with heart failure and you discovered that ejection fraction is 35-40, can you start your ARNI on the hospital?
For now, yes, but thinking before.
For now, yes. So this is the trial which was done for the in-hospital admission was just finished like 2021 or something like this. Or 20. So, you know, the questions of Saudi Council, sometimes it will be adapted from questions that is already established. So usually they don't ask about very, very, very updated things. But yes, answering your question, the patient can be started on ARNI directly. Even a patient who have like mildly reduced ejection fraction or preserved ejection fraction have indication for ARNI and SGL2 by the trials that we know. Okay, and they both so SGL2 will have a mortality benefit and preserved that we talked about, and even ARNI will have a significant reduction in rehospitalization, but not mortality. Okay.
زي the question يا بص الكويشن بتاع الهارت البروجنوزيس correlated most strongly with which of the following: patient impaired renal function or resting ejection fraction. Yeah. The answer is A or C.
So the answer is A. The answer is
impaired renal function.
Impaired renal function. So if you attended the last Saudi Heart, my lecture was about heart failure and CKD. Okay, and in the first few slides, I just talked strongly about the prognosis of patient with heart failure, and even at any place, you know, my program director when I was in fellowship was always saying, if you have a patient with normal renal function, you can do a lot of things. If you have a patient with impaired renal function, then you're just crippled. The prognosis is bad. Whatever you do, the prognosis is bad. Because with the impaired renal function, regardless of prognosis, let us imagine that prognosis is the same. There is difficulty with starting ACE, ARNI, MRIs, because there is always need to monitor. You need to bring the patient every now and then for testing. Otherwise, they will have hyperkalemia, acute kidney injury, etc., etc. And then, if those patients are for transplant, then transplant centers usually do not like them. Okay, they will like somebody who had an EF of 10%, but they will not like a person who has a creatinine of 200. You know that, because they will imagine that the kidney function will be worse and the transplanted heart will be in bad situation. The patient will not do overall even after transplant. So yeah, so impaired renal function is the most important tool in strongly correlating with prognosis.
Thank you. بس يا وصل, I think the ARNI should be started only symptomatic heart failure, but stage B only ACE inhibitor only.
Yes.
If
So we might have recommendation. We might have recommendations soon about this. So all of the questions that we had in the past came that ARNI can be started. So I think ARNI soon will be started as for stage B.
Yes, stage, according to the last American guidelines, stage B only
Yes.
ACE inhibitor.
Stage what again?
Stage B only ACE inhibitor or ARBs, but ARNI not for stage C only.
No, that's what's mentioned in the slides. So anything that is more than stage 4. So if you have NEHA class 2, NEHA class 3.
Yes, symptomatic only.
Because you need trials of on patients who are in the stage to say that we can start those patients who are in the stage. And of course, we know it will work. It will work. If you start a patient who is in the stage in ARNI, this will work because it has the same compound, same everything. The results have been reproduced 3 times, but you lack the guidance. You do not
no study. Still there is no study for this.
Yes, definitely.
Thank you very much.
You are welcome. Okay, thank you very much. So probably next week, Dr. Faisal will have a lecture about acute decompensation heart failure.